So then what about MRSA? This was a wonderful program. I want to commend it to all of you, the MRSA surveillance program. This is not just about patient safety. This is about something that you also said. That's about worker safety, right? The people that actually have to work in the cesspools that sometimes characterize our ICUs. The cesspools of resistant bacteria that Ed spoke so, I think, poignantly to this morning. So what we said to get this launching was, we said to our nurses and to all our workers, we're worried about you being exposed to people inadvertently who may have MRSA. And we're worried you may be taking it home, and that's not a good thing. So we want to protect you, and we want to protect our patients. So what we're going to ask you to do is we're going to ask you to do a nasal swab on everybody that enters the unit, to define those individuals who may be carrying MRSA, who we wouldn't otherwise know. And we're going to ask you to do it every 7 days to find out, do people that come in negative for MRSA actually turn positive while they're here? So we could figure out what the defect was. And I said, because we want to do this, we also need you to adhere to what we know are the barrier precautions. Because the barrier precautions are not just to protect the patients, they're actually to protect you. Because you are no more protected from this than a patient. Unbelievable. 95% compliance with a very rigorous surveillance technique within 1 month by the workers. Why? Because the buzz in the unit was, they're actually concerned about our safety. So, we had 236 MRSA infections. We got $40,000 for every case. We cost us $54,000. We were losing $13,000 on every MRSA. Just what Ed told you this morning. We didn't make these data up. He gave you some general data. I'm giving you our specific data. We were losing $3 million a year in operating losses attributable to the losses in MRSA infections. And not only that, 49% of the patients got readmitted. So we started the MRSA surveillance program. It took us 8 months to pilot it. We looked at 2,100 admissions in the ICU in FY06, 95% compliance with the admission and discharge cultures. We found 139 patients who were not known to carry MRSA who actually had it, and in whom we were able to initiate barrier precautions before it could be transmitted. And we found a very, very, very low rate of transmission once we did this. So if you looked in fiscal year 2004, we had 22 patients in the ICU, in the MICU and CCU who developed MRSA infections. 11 of them died. And if we look 2 years later, we only had 3 MRSA infections and nobody died. So we had an 86% reduction in MRSA infections in the ICU over this period. If you look at our surgical units, at the start they had 56 infections. They decided they didn't want to do the surveillance. At the end they had 87, and they eventually saw the light. Because the nurses in the CCU and MICU would say, why aren't your doctors interested in protecting you from getting this? Peer pressure is a wonderful thing. So the cost of the surveillance, it does cost sometimes, was $50,000. Again, I got a grant to do this, the hospital didn't pay for it. We saved about $15,000 in every MRSA infection we prevented. That meant we had to prevent 4 infections to pay for the cost of the surveillance. We actually prevented 19, so we did pretty well. So this is what happened. Here's the central line associated bloodstream infection work. We started that first. A year later, we started the ventilator-associated pneumonia. And we didn't start the MRSA thing until out here. But look what happened to MRSA infections just by controlling bloodstream infections and ventilator-associated pneumonias. We had dramatically reduced our task because we created a culture of safety. Not just a project, a culture. Not just today's to-do list, a precondition of work. Such that all of a sudden, everything becomes safer when you create the culture. So what about the economics of this overall? Over a 2-year period, we improved the operating performance. Now let me just begin. At the start of this 26-bed ICU was losing about $1 million a year in operations. So what we did was we took all the revenue and all the expenses, everything loaded, directs, indirects into the equation. We were losing about $1 million a year. Chief Financial Officer says, got to fix that. You know, or I'm not going to fill the respiratory therapy position, or I'm not going to hire them. And so what we did was, by reducing these rates, we improved the operating margin by $1.2 million attributable to CLABS, $1 million attributable to VAPS, and $295,000 attributable to this, to the MRSA infections. In addition, Highmark, which is the largest payer in Western Pennsylvania, paid the hospital a $3.1 million pay-for-performance bonus. meant that the elimination of infections that no one wanted netted an improvement in operation of $5.6 million in 26 ICU beds. And we did spend $85,000 to get this up and rolling. We admitted 188 additional patients, and we, according to IHI, saved 57 lives. In fact, safety is the third most profitable division in my department. Cardiology and oncology eke it out a little bit, but safety's third. Third most profitable product.